Good afternoon, everyone, and welcome to today's session titled Interim IPAC Recommendations for the Use of Personal Protective Equipment for Care of Individuals with Confirmed or Suspected COVID-19. My name is Tim Cronsberry, and I'm the manager of the Infection Prevention and Control Program at Public Health Ontario, and I'll serve as today's moderator. This webinar today is specifically targeted towards public health units. So the content of the webinar is really going to reflect the technical brief upon which the webinar is built, and also specifically will outline the specifics of that content and its implications for both the long-term care and retirement home setting, as well as the acute care setting, and how that might assist public health units and others in supporting those sectors. Just before we start today's presentation, just a few housekeeping items. There is a Q&A pod that you'll see as part of the Zoom platform, and at any point in the presentation, if you have a question that comes to mind, you can enter it into that Q&A pod. We won't be answering those questions until the end, but there's plenty of time at the end of the presentation to do the Q&A. So hopefully we'll be able to get to all of your questions. If at any point during the presentation, if you have technical difficulties, just have a look in the chat pod, and you'll see an email address to our capacity building team that may help you troubleshoot that. The presenters for today are two, Dr. Michelle Science, and Dr. Science is one of our IPAC physicians at Public Health Ontario, and the other speaker is Sandra Callery, who is a senior IPAC advisor in the Health Protection Department at Public Health Ontario. So with that, we will move into the presentation. And again, just the terms of use slide. Again, as you all know, our work at Public Health Ontario is guided by the best available evidence, and we really strive to be responsive to the needs of our stakeholders and base that on the available evidence. Before we move any further, we just wanted to do a poll question, and that poll question you'll see on the screen in front of you now. Have you reviewed the interim PPE guidance upon which, or the technical brief upon which the webinar is based? So if you can just choose one of those options. Thank you very much. And a significant percentage, 76% of you are responding that you have indeed reviewed those interim PPE guidance, which is great. It will help you to think about the questions that you might have regarding that material. But even if you haven't had a chance to look at it, hopefully the webinar today will assist you in kind of digesting some of that material and knowing what is new. So the objectives of the session today is to describe the layers of protection when caring for those with suspect or confirmed COVID-19, to discuss the use of personal protective equipment and other IPAC measures based on an individual risk assessment, and to identify the implementation of any required changes within the care environment. And again, the care environment we're talking about in this context is both long-term care and retirement homes, as well as the acute care setting. So right now I will turn things over to Dr. Science to get us underway.
Great, thanks so much, Tim. So I'm going to start off by speaking very briefly about variants of concern. And I probably don't need to provide too much detail to this group. If you could advance to the next slide. Great. So variants are viruses that have changed or mutated, which commonly occurs with coronaviruses. However, a variant becomes a variant of concern, or VOC, when its changes have clinical or public health significance that affects one or more of its transmissibility, virulence, vaccine effectiveness, or diagnostic testing. And I just want to draw your attention to this document, which is shown on the left there, from PHO and PIDAC, which provides interim guidance for infection prevention and control of SARS-CoV-2 variants of concern for healthcare settings. So now moving on to the most recent variant of concern, which is the Omicron variant, or B11529. And this variant was designated a VOC by the World Health Organization on November 26, 2021. Its detection in South Africa coincided with rapid increases in COVID-19 incidence and positivity rates. And in that area, only 24% of the eligible population is fully vaccinated. Now, compared to other VOCs, it carries the highest number of novel mutations, and we're still learning the significance of those mutations. And as of December 17th, 2021, most cases are likely to be infected with the Omicron variant. Next slide. So this graph shows us the confirmed COVID-19 cases with a variant of concern, and it's from October 31st to December 20th, 2021. And so you can see the red bars there represent the Delta variant, and the light blue are those with S gene target failure, which is consistent with the Omicron variant. And here is a little bit more information on what we know about the Omicron variant. So really early evidence indicates that there is increased transmissibility as well as decreased vaccine effectiveness. And the mechanisms for this increased transmissibility are unclear. So at this stage, we're uncertain if the respiratory particles could contain more infectious virus that may explain the higher transmissibility. And the last point there is just around the lower vaccine effectiveness that suggests that for any given exposure, there is a greater likelihood of infection. Okay, now lastly, before we move on to changes in the technical brief, we wanted to give some background information regarding the key terms that we're hearing, like airborne and opportunistic aerosol transmission. So airborne in the IPAC community really has a special meaning, and it describes infections that are efficiently transmitted by inhalation of aerosols that have remained suspended in the air for a long period of time or an air occurrence over long distances. When we talk about opportunistic aerosol transmission, we're really talking about transmission that is occurring under the right combination of conditions. So for example, poorly ventilated spaces and a sufficient quantity of infectious virus produced. In other words, it occurs less frequently and less efficiently, but can occur under the right set of circumstances. And so now I'll pass it on to Sandra to review the updated interim guidance.
Thank you very much, Dr. Science. So we'll move on to the next slide and remind you of the technical brief that we have recently updated. So we have interim recommendations for PPE. And as just described, we've certainly been monitoring over the course of the pandemic over the past 2 years how our layers of protection, how our personal protective equipment has worked, what has been effective, and monitoring that. And we have been monitoring that with all of the various variants of concern. We are now introduced to Omicron and are now continuing to keep a close eye on how our practices, our precautionary measures are working. And so with that in mind, our technical brief was reviewed and we looked at, for the interim, any additional changes that we might need to make in the layers of protection. And as it says here in the slide, we wanted to look at the personal protective equipment for those who are directly involved with the patients or residents with suspect or confirmed COVID-19. So on the next slide, it's important, as I mentioned, to know that one of the things we have monitored over the course of the pandemic is actually the use of masks and the use of respirators. And there has been actually limited evidence to show a benefit to the N95 respirator over medical masks when caring for patients with known or suspected COVID-19. Now, I say that in terms of the previous variants of concern that we have been closely monitoring over the course of the pandemic. Now with Omicron and the fact that it's new for us and continue to monitor, it's prudent for us now to take a closer look at what we should be providing for our healthcare workers. And based on this undetermined impact of Omicron at this point in time, we've taken our technical brief to describe personal protective equipment in a slightly different way than we have in the past. So now we're recommending the N95 respirator, gloves, gown, and eye protection for those who are involved with the direct care of either patients or residents who are suspected or positive for COVID-19. I think it's important to note at the bottom of the slide that directive number 5, I will be presenting the PHO recommendations and how we have followed the science. But I think we all realize that the Ministry of Health directive number 5 is the provincial baseline standard to follow. Next slide. So let's take a closer look at those changes to the personal protective equipment. And if we take this to a long-term care setting for direct care to residents who are suspect or confirmed, we had recommended a medical mask, isolation gown, gloves, and eye protection. For the interim, we are recommending that we use a fit-tested N95 respirator with an isolation gown, gloves, or eye protection. However, based on the fact that we still have limited evidence to show that it makes a difference, we, if necessary, based on a risk assessment, a medical mask or a non-fit tested N95 respirator or equivalent could be used, but this should be based on your personal risk assessment. So the isolation gown, gloves, and eye protection continue to be in place. And again, these are PHO recommendations based on the evidence, but the directive number 5 would be the standard to follow. And the next slide, if we talk about an aerosol generating medical procedure, most typically in long-term care settings, people are very comfortable, very familiar with, I should say, the CPAP equipment or open suctioning is often used as examples. We have recommended that the PPE would be for those types of aerosol generating procedures, a fit tested N95 respirator, isolation gown, gloves, and eye protection. They should be managed in a single room with the door closed, and we should keep the number of people in the room during the procedure to a minimum. So for the interim guidance that we've provided, there's really no change in those recommendations. So if we take a look at another scenario with environmental services workers entering the room of a resident with suspect or confirmed COVID, we again previously had recommended that they wear a medical mask, isolation gown, gloves, and eye protection. For the interim, particularly when the environmental services workers coming into the room and cleaning the room, in and around the space, the residents' environment of care, we are recommending a fit tested N95 respirator with the isolation gown, gloves, and eye protection. And again, based on risk assessment, we do think that it would be acceptable to wear a well-fitting medical mask so that fits snugly on the face, or a non-fit tested respirator or equivalent. Isolation gown, gloves, and eye protection should also be worn. The next scenario is really around visitors. And our previous recommendations for visitors was actually to wear a medical mask, again, isolation gown, gloves, eye protection. It was recommended that visitors should be kept to a minimum in rooms with known positive or suspect cases of COVID-19. For the interim, again, we continue to recommend a medical mask or a non-fit tested N95 respirator. Again, making sure they fit snugly to the face, isolation gown, glove, eye protection. Again, limiting those to only those providing essential care. And really, all homes should be considering restricting the essential visitors to those fully vaccinated, or certainly encouraging that to be the case. So now we have another polling question for you. And in this polling, you are about to do continence care on a confirmed COVID-19 resident. So what would be the PPE recommended for this task? So please put your selection in the poll. And I see, yes, the majority have picked the N95 respirator with gloves, gown, and eye protection, and which is the answer we were looking for. This wasn't really a trick question, but what we wanted to emphasize here is that although we are completely preoccupied with COVID-19 and the pandemic and the protective apparel for that particular infectious disease, it is really important to remember that we also want our healthcare workers protected from exposures to blood and body fluids. So it's important to remember all of the other routine practices that should be in place. And with that, I mean, for example, the gloves when you're carrying out continence care, and the hand hygiene and the changing of gloves. So thank you for that. Now we're going to move on to some of the interim guidance for hospitals and inpatient facilities. And for the direct care with patients for suspect or confirmed cases, as previously recommended, we had medical masks, isolation gown, gloves, and eye protections. The interim guidance that we're recommending is, again, a fit tested N95 respirator with isolation gown, gloves, and eye protection. Again, if based on the organization and the risk assessment, whether it includes medical mask or non-fitted N95 or equivalent isolation gown, gloves, and eye protection. So we'll keep, as I mentioned before, we'll continue at PHO to monitor the epidemiology, what we're seeing in outbreaks and transmission, and where we can identify any shifts or changes in recommendations around the personal protective equipment. Now, during aerosol generating procedures in acute care settings for suspect or confirmed cases, we previously had recommended a fit tested N95 respirator along with the other protective apparel of gown, gloves, and eye protection. Also a negative pressure room if available. For the interim, we have no changes recommended for dealing with the Omicron variant. The next scenario is an environmental services worker entering the room of patients with a suspect or confirmed COVID-19. So previously, we had recommended medical mask, isolation gown, gloves, and eye protection. The environmental services worker entering and cleaning a room currently with suspect or confirmed COVID-19, our interim recommendation is the fit tested N95 respirator and isolation gown, gloves, and eye protection. And again, much of this is based on the time in the room and the interaction that they have with the patient and the patient environment and the environment of care. So all of those things come into play. Next slide. For visitors entering the room of a patient, you can see again that we have similar to what we have mentioned in our long-term care settings. We had previously recommended the medical mask and the other precautionary protective apparel, isolation gown, gloves, eye protection. We had previously recommended that visitors should be kept to a minimum. In this case, in the interim, again, medical mask or a non-fit tested respirator, isolation gown, gloves, eye protection, limited to those providing essential care. So a little bit more restrictions in terms of visitors is recommended, and also consider restricting to those who are fully vaccinated. Another scenario for acute care that comes up frequently is around triage. So that preliminary screening of patients at point of entry. So if able to maintain spatial distancing, we had, and with barriers, we had previously recommended routine practices. Otherwise, we had recommended PPE and the medical mask, isolation gown, gloves, eye protection. In the interim measures and guidance that we're providing, again, if able to maintain spatial distance or separated by physical barrier, routine practices. Otherwise, however, it's recommended that they wear a medical mask, non-fit tested N95 respirator equivalent, along with isolation gown, gloves, and eye protection. It's important to note that at this stage, the patient who is coming forward should have been provided a medical mask to accompany, and those accompanying the patient, a caregiver, for example, should also be provided a medical mask. For any screening of any patient with suspect or confirmed N95, in addition to the above, should provide that patient with a medical mask if tolerated, and perform hand hygiene in front of the person at the triage desk. So again, it's just being very observant and making sure that those coming at the triage desk have a medical mask on in place, and making sure that there are, wherever possible, separation with a physical barrier. Now, another polling question. A nurse is about to do an aseptic procedure on a confirmed COVID-19 patient in hospital. So what PPE is recommended for this task? We have three choices here. Yes, so the response, the N95 respirator, because this is a COVID positive case, gloves, gown, eye protection. And because it's an aseptic procedure, I'm going to emphasize the importance of hand hygiene before donning the gloves. And the gloves should be a clean pair of gloves for that aseptic procedure, and the gloves and hand hygiene performed, gloves removed and hand hygiene performed at the end of the procedure or the task. So thank you for answering the poll. And I'm going to turn it back over to Dr. Science for the IPAC controls and risk assessment.
Great, thank you so much, Sandra. So as you mentioned, I'm going to speak about some of the IPAC controls and the individual risk assessment. And so many of you will have seen this before. It's the hierarchy of controls from the CDC, which is an approach to the containment of hazards in the workplace. So it describes the layered occupational health and safety approaches. And at the top of this triangle or pyramid are the most effective strategies. So this includes the elimination or removal of the hazard. And then there's substitution, engineering controls, administrative controls, and personal protective equipment. And with respect to SARS-CoV-2, so some of the engineering controls include things like ventilation, cleaning and disinfection. When we speak of administrative controls, this includes things like physical distancing, optimizing patient flow, and vaccination programs. And then at the bottom, although it's at the bottom, still important, are personal protective equipment. So masks, respirators, gowns, gloves, and eye protection. And so even though I mentioned it's at the bottom, that the personal protective equipment, it still is important to make sure people are using it correctly. So again, probably many of you are familiar with how to properly wear a mask, but making sure it is in fact covering at the mouth and nose, and there isn't gaping occurring at the sides or at the top of the mask. So you can see the pictures on the left there, which are the do not do, and then the ones on the right, how to appropriately wear a medical mask. Okay, so the individual risk assessment. So this assessment considers the task that the individual is going to do, any interaction with others, and the environment. And we emphasize that it should be completed by the healthcare worker before any patient interaction or task, so they can determine their risk of being exposed to an infection and appropriately protect themselves. So it allows them to select the correct personal protective equipment required to both protect the healthcare worker and also other staff in their interaction with the patient and the patient's environment. So really important that healthcare workers should receive education and training on how to effectively perform a risk assessment so that this can be done appropriately. So with respect to SARS-CoV-2, some of the risk factors that may increase transmission and infection risk. So things that the healthcare worker would choose to consider in their individual risk assessment would be the healthcare worker vaccination status. So whether or not they're vaccinated, and then 2 versus 3 doses versus 1 dose of the vaccine, and the level of protection that that provides. And then resident or patient factors. So patients that are unable to mask for source control would present a higher risk than those that are able to mask for source control. And then whether or not the resident or patient is vaccinated. And then the interaction. So what we continue to see over the course of the pandemic is that really prolonged close contact is the highest risk for transmission. So if you're in close contact, so within 1 meter for any prolonged period of time, that would increase the risk associated with that interaction. As well as if you're performing, or if the healthcare worker is performing a high-risk procedure. So what exactly does that mean? So high-risk procedures include procedures like aerosol generating medical procedures, or AGMP, which are procedures that have been epidemiologically linked to have a higher risk of transmission, but also some other procedures that have heuristic to aerosol generating medical procedures, in that they have really close proximity to an individual's airway or otherwise. And so for those high risk procedures, you might consider an N95 respirator, and for aerosol generating medical procedures, it is required as a minimum level of protection. Next slide. Okay, so now just moving on to another polling question. So based on the hierarchy of controls, which is the most effective? And this is a single choice answer. So engineering controls, including ventilation, cleaning and disinfection, administrative controls, physical distancing, patient flow and vaccination, or personal protective equipment, including masks, respirators, gowns, gloves, and eye protection. Okay, great. So many of you chose the right answer. So the engineering controls are higher up in the hierarchy of controls before the administrative and the personal protective equipment. All right, so moving over back to Sandra.
Thank you. We're talking a little bit more now about multiple layers of prevention. And as I mentioned earlier, we did spend a great deal of time over the last 2 years looking at the epidemiology, looking at disease transmission and what works and what doesn't work. And so it's important to know that all the different layers of prevention that are recommended all play some role in effectively helping reduce the transmission or prevent the transmission. I think it's also really important to remind our healthcare workers that the risk of COVID-19, it is a pandemic after all, it's affected all of us in our personal lives as well as in our work life, but it still is important to remind people that the risk of COVID-19 or infection and exposures do not just exist within the workplace, but occur in our personal lives and in the community as well. And sometimes what we sometimes see is people have been very diligent, very conscientious in the workplace, and then they just relax a little bit as they leave the workplace and head for home. So it's important to remind them that their risk of exposure is as great in the community at large as it is within their workplace. So the protection of healthcare workers requires those multiple layers of prevention, both in the community as well as in the workplace. And all of these layers, as I said, are aimed at reducing transmission and have shown some evidence to support that. So the public health measures that many of you are very much aware of and promoting, particularly the vaccination and other layered preventative measures, physical distancing, the masking, getting tested, staying home when you're sick, are all really key important prevention strategies that sometimes in the busyness of life or in the work that we're doing, we become very absorbed in what we're doing. We sometimes forget certain elements that could also help protect us during our workplace. So those are the things that we need to remind everyone. And this diagram, we really like the Swiss cheese model here. And it just highlights all the key elements that are so important. The hand hygiene, the masking, of course, seems to be more pronounced right now in terms of what everyone is thinking. But the physical distancing itself is very effective. Making sure that you're in a well-ventilated space. Staying home when ill. And this is a time when I think people often ignore, in the busyness of life, often ignore those subtle twinges, the new onset of a headache, something that they may not necessarily associate with COVID-19 right away. So it's really important that people start to think about when they're not feeling well and staying home when sick. And of course, the vaccination and its incredibly important role in the transmission of this, in preventing the transmission of this particular disease. So this is actually needs to be emphasized, but that people need to know that it's the consistency by which we use all of these layers that can make a difference in our own personal outcome. So in the next slide, we want to just highlight for you some of the resources that we have available to help you remind people and refresh their memory. For the last 2 years, people have been putting on and taking off protective equipment, but even the best of us, myself included, you can become a little complacent in how you do it if you're doing it day after day. So making sure people look and observe and help each other and in monitoring for the donning and doffing or putting on and removing the PPE, use those lanyard cards if they help. We have some great videos that might be very helpful on how to don and remove respirators. Again, it's a piece of protective equipment that not everyone is as comfortable with. So certainly take a look at those PHO videos for that as well. And we've also linked you to the newest iteration of Directive Number 5 in the link with the presentation. We also know that it's important for you to be able to reach out to us with additional questions. And I'm going to be turning this over to Tim, but you can see contact information on how to get a hold of us. And if you have additional questions, but I do think we do have time for questions now. So I'm turning it over to Tim.
Yes, thank you very much, Sandra, and thank you very much, Dr. Science, as well. So we will move into our Q&A portion now, and we have a number of questions that, again, people have asked early in the presentation, and I think they've been answered by the subsequent material. But we'll just we'll outline a few of those just for those to make sure that that we're all on the same page with those. So there are a few questions about the use of masks and different tasks, not just tasks, but different healthcare workers within these settings. So not so much the nurses and PSWs, for instance, and the physicians, but some of those dietary staff and others who may be in and out of the room. And again, I know some of the content covered it, but if you could just quickly go over that again to say someone who works in dietary, if they're going into the room of someone who is a suspect or confirmed COVID-19 patient, what would the required PPE be?
Well, I'll begin, and Dr. Science can certainly chime in as well. First, so we are recommending that people who are entering the rooms and for a person who is known or positive or suspect to wear their fit tested N95 respirator. I think it's also important to consider what we mean by that, because meal tray service sometimes is varying. It may be that the tray is left at the doorway. It may be that but in a long-term care home, that particular dietary staff member may actually set up the meal tray at the bedside or wherever the resident may be sitting. So there can be varying degrees. And with that in mind, you have to look at whether or not a medical mask, a good fitting medical mask, especially if they're just passing through, is one element. But if they are going to spend any time in that room, or if they're going to actually help assist with the tray setup at the bedside, then that would require, for those on precautions, the N95 fit tested respirator. Dr. Science, I don't know.
Thanks, Sandra. Not too much to add. In the updated technical brief, we do talk about transient activities, the patient room, and entering that room, and the option for a medical mask, just given the transient nature of in and out of the room. But important to refer to Directive 5, which does talk about the N95 respirator for direct patient care or patient interactions. And so that would, even though it is transient and from the perspective in the document, the risk is lower based on the brief nature, would have to refer to Directive 5 in terms of what's required.
And just picking up on that, because again, this webinar today is more directed towards a public health unit audience. There was a question in the chat posed about mass vaccination clinics. So we know that those are, they've always been important, but there's increasing focus on them now with the Omicron variant. Can you comment at all for public health nurses and others in that immunization setting?
So I'm happy to start, or Sandra, if you. So I think it's a really great question. And one thing to just draw attention to is that this document or technical brief is really for patients with suspect or confirmed SARS-CoV-2 infection. So people who are symptomatic or who have had an exposure and shouldn't be out in the community at these mass vaccination clinics. So that's one difference just to draw people's attention to. And I think the question about masking guidance for other settings has come up a lot. And just as a starting point, I did want to draw everyone's attention to the recent evidence brief on Omicron and masking in the community, which really emphasized the importance of optimizing fit and filtration, which can be achieved by wearing a non-fit tested respirator N95 or KN95 or a well-fitted medical mask. But those are for sort of community setting. And to answer sort of the direct question, we are working on a document about masking in other workplace settings that will be coming eventually. But Sandra, anything else specifically about the vaccination clinics?
No, I don't think so. I think, as you said, people who are coming to the vaccination clinics are also to self-assess prior to coming. They are also asked questions at arrival. Often if they're not wearing, if they're wearing an ill-fitting medical mask or a mask, they're often, it's typically they are given a medical mask to apply at that point in time. So again, we don't see any changes for those types of settings. Our interim guidance has really been directed for those who are considered exposed, high risk, you suspect they're symptomatic, waiting for confirmation, or those who have been diagnosed.
All right, thank you very much for that additional context and introducing that idea of other settings as well. So good to hear that there are some other PHO products that are being worked on that will help those in public health units to answer questions from those other settings and workplaces. So another question is, it's an interesting question. Why N95s now? So, and I know, Dr. Science, you went over some of the intricacies of the Omicron variant, but again, probably a good opportunity for us to reinforce what's different now that has led to the changes to PHO's recommendation around respirators.
Well, I will begin by saying that because being involved in the interim document, the technical brief, what we have been watching and is a very easily transmitted variant of concern. And with that being said, and the fact that it's so very new to us in terms of how it plays out, how we're finding our own personal protective equipment, our practices, how well they are in preventing or halting transmission, those are the things that we want to watch and monitor. And I think I don't want to lose sight of the word that we've used, interim, and that's actually so that we can gather more evidence and more information to know whether or not these measures are really needed, or if our measures up to this point in time will be acceptable, i.e. A good fitting medical mask and the hand hygiene. We do also know that with this variant, the 2 doses of our vaccine have had limited efficacy. So it's the fact that we have not yet got our population boosted to the level that may provide additional protection. That's the other thing. We're definitely in an interim stage in terms of monitoring this particular variant. Dr. Science?
Sure, maybe just to, so if you do read the technical brief in detail, you'll see that the evidence review really found that the protection between medical masks and respirators is expected to be marginal, but just to flag that this data is from sort of earlier in the pandemic, and to Sandra's point, with the significant increase in transmissibility with Omicron, and sort of unclear if the change is related to a potential increases in infectiousness of aerosols as a possible explanation. That's why this interim guidance is in place as we gather more information, but it will continue to be reassessed as we learn more.
All right, thank you. Also, a few questions about clarifying the term suspect case. So we've said suspect, confirmed, probable, and again, I guess it links back to you know, the context-wise at the current time of year, and perhaps more so in the long-term care setting, there may be more traffic of residents of long-term care going in and out and to family events, even though, again, with the Omicron variant, you would want to really consider what those activities would be. But regardless, in that context, a suspect, if someone was coming back into a long-term care home, or a new resident to a long-term care home, and they were awaiting test results, is that what a suspect case means? And is there other context around that that would be applicable?
Well, I'll begin. It's certainly for this presentation, and our recommendations are around those cases that you feel that they've had a high risk exposure. They may be presenting with symptoms that yet are to be diagnosed. So that in the context of, for me, that's the context in which I use the term suspect, and it's suspect in terms of you wanting to put into place additional precautions for that particular resident or patient. So, Michelle, I'm not sure if you have anything else.
And nothing to add, Sandra. Exactly those patients that you would be putting in additional precautions because you are concerned that they either have SARS-CoV-2 or could be incubating.
Right, and again, picking up more along that theme. So a good scenario in a long-term care home, for instance, or a retirement home where there is an outbreak. So in the scenario where there is an outbreak on an entire unit, questions around the use of PPE in that situation. So where you're not necessarily having everyone on additional precautions, but because it's in an outbreak unit, should staff, visitors, and others be using that PPE outside of the situation of bedside care with someone who is confirmed suspect or probable?
In the context of an outbreak unit, I think is what you said here, Tim. So again, it may depend. It depends sometimes where you are in the outbreak, and those on the line today know better than most of us around, because you're always involved when an outbreak is declared. Public health is actively involved, and if it's at the very beginning of an outbreak on a particular unit, where you're more concerned about where the transmission is, you haven't identified the source, or you feel that there might be several people in an incubating, that may be where you look at in this particular case, you're talking about N95 respirator use in both in the resident rooms or in the common areas within that unit. That might be a consideration. However, you're at the other end of the spectrum where you're in an outbreak, but it's in the resolving stage, and you have identified key cases that should be still on their additional precautions. Then you can look at, again, your medical mask, your universal masking, and wearing your N95 respirator for direct care for those that are still suspect or positive cases. But I think it really depends on where you are in that spectrum of called an outbreak, and where you see the epidemiology and how well controlled you think it is in terms of transmission on the unit. And what we always say to any home or acute care facility that reaches out to us is that they should be working really closely with people such as yourselves, the local public health unit, to determine how you want to manage that outbreak in particular.
All right, thank you. Some additional questions around the doffing of PPE, and with that, I guess I don't like this term, but extended use. So the idea that I know under normal circumstances, and we are certainly not in a normal period of time, but IPAC best practice would say that if someone is on droplet and contact precautions, then when you finished your interaction with them, i.e. at the exit to the room, you would doff the PPE. But there are some questions, very legitimate questions of are there situations now, particularly with N95 respirators, where you wouldn't necessarily need to doff that PPE at the door? And I imagine it relates to the type of activity that is being interacted with the patient or resident. But if you could comment on that.
I'm not sure, Dr. Science, if you, Dr. Science is certainly in the clinical space a great deal right now, so she may want to comment as well around the extended use. We've always said, we've always wanted to ensure that people aren't, that this isn't the first option that they choose to extend the use of any protective apparel. However, I realize that there may be circumstances and where extended use may occur. It's so important that people not touch and manipulate their masks on a regular basis, that they perform hand hygiene if they inadvertently have to touch the respirator if they're wearing it. If they do have to remove it or adjust it, they should replace it. We have not been promoting, as a rule, the reuse of respirators. So extended use versus reuse are two different things. So I'll just pause there because Dr. Science might want to.
Thanks, Sandra. I completely agree, as always, with everything that you said. And you know, Tim, you alluded to best practice, but you know, practically speaking, there may be times where extended use will be necessary. And to Sandra's point, just really important to do that. You know, assess what your interaction is going to be, and you know, do your risk assessment. And if you do, you know, if you're going in the room and doing an AGMP or something where where the outside of the mask may become more heavily contaminated, that's a circumstance where you may really want to change it, versus a brief interaction in the room where extended use may be reasonable, but making sure that people understand some of the risks with extended use in terms of not touching their mask and performing frequent hand hygiene and all of those factors.
And then I'll just, pardon the pun, but I'm going to layer a question on top of that. And it actually is a question about layering. So there have been a couple of questions about, you know, in that scenario where you may want to not change the N95, why not put a medical mask over top? And that be the one that that you change. And I know that we shouldn't be doing that, but if you can address that, because there has been a couple of questions about it.
Well, we have had this discussion in the past, so we were not surprised about your question, Tim. I think there are some concerns that people need to think about when they decide this would be a great way to preserve my N95 respirator for a little bit longer. First of all, manipulating and putting another mask on top of your respirator may be challenging for some people in terms of the breathability. So you have to think from an occupational health and safety perspective, am I actually interfering with my own ability to breathe comfortably? And do I manipulate or adjust that external mask way too often? And so those are two other things. I think you also have to make sure that it doesn't somehow interfere with the fit test. You've just had you're wearing a fit tested respirator for a reason. And so if you are placing another mask on top that might interfere with that, or set it ajar, if you will, on your face and not provide the seal that is most important when you're wearing a respirator, then those are things you have to consider before doing that type of practice. Dr. Science, I'm not sure if you want to add.
Nothing else to add, Sandra.
All right, thanks. I'm just conscious of our time, and there's a couple more questions that I want to get to. And one is around wording that we use in the technical brief. We say it in a few places, N95 or equivalent. So great question. What is equivalent? And I know that there is a pervasive use of KN95 masks and FN95 masks, and there's a whole variety of them. So if you could comment on what that means as an equivalent.
So, okay, I'm happy to start. So there are many different models of respirators on the market, including the KN95 you spoke about, the FFP2 and others. And so just to flag, some of these may meet standards for the filter efficiency, but not all models do. So if the respirator model meets filtration criteria, wearers still need to be fit tested if they want to use it as an N95 equivalent. If it does not meet the filtering or filter efficiency criteria, then it can't be considered equivalent to an N95 or a fit tested N95 respirator.
Great, thank you very much for that. And just drawing everyone's attention to the chat pod as well. So related to the question that Dr. Science just answered, there's a couple of links in there that will take you to a Health Canada website that talks more about masks that are approved for use, and that will hopefully give some additional information there. And let me just see that. I guess the last question that we'll have time for is just a question around, this is a technical brief produced by Public Health Ontario and PIDAC. And I guess, Sandra, I'm going to reinforce a point that you made in the presentation as well. And the difference between a recommendation that is coming from PHO and PIDAC and the provincial directives. So again, it's probably a good opportunity for us to just reinforce the difference there.
Yes, I think it's important to say to note that one of our roles at Public Health Ontario is to provide scientific and technical advice, and certainly that advice is shared with people such as yourselves on the webinar today and with the ministry as well. That information is taken in, and then the directives or the decisions are made by the ministry, and these are the directives to follow. But I think we felt it's really important for you to hear from us, from PHO, where we have found the evidence, how we're following the evidence, if you will, as well, and making sure that we can provide the best possible advice to both yourselves and the ministry.
All right. Well, thank you very much, Sandra and Dr. Science, for providing our content for the webinar today. Thanks to all of you participants for asking the questions that you put into the chat pod. Following this webinar, you'll receive an email. And if I can just ask you to take a couple of minutes and complete the survey, it really helps PHO to follow up and to improve the way that we present this type of information. I also just want to say that I know not just at this time of year, but it has been, everyone is very, very tired. And I know that Omicron has put even heaps more pressure on everyone, not just in public health units, but all across the healthcare system and in other settings as well. And just want to say from PHO, thank you very much to everyone for doing the work that you do. We all know it's hard, but we also know that we have to keep going, and we will get over this. It's just unfortunately going to take a little while longer. So with that, thank you very much again for participating, and enjoy the rest of your day.